Thank you very much to everybody, and it's a great honor. And thank you above all to Manos and Manos for the invitation. So now when we talk about, sorry, with this one? Okay. Oh. When we talk about patch, I have in my mind some question. Why do we need a patch and rotator cuff pair is the first one. Which kind of patch can we use? Which technique is more effective? And which is the ABM about the use of patches? For the first one, for the first question, it's easy because we have a returning rate that is so high, but here it's not too bad. But in many studies, we arrived at 50%. So we are still looking for a biological improvement in repairing the cuff, because in the past we have tried to do everything to improve the mechanical effect. But we are looking for also the restoring and the recreating of the tendon enthesis, that it's a very, very hard work because it's very important, but it's very difficult to think about that and to think that it's possible to recreate it. So, which kind of patch do you use? Autograft, allograft, xenografts, synthetic? We have a lot of patches, so it's very difficult to understand. The ideal scaffold should have adequate initial mechanical properties and be slowly degrading and not degradable, and have not toxic degradation products, so enhance cell growth, infiltration, and differentiation. And in literature, we found that in summary, biological patches and augments are helpful in a large and massive rotator cuff repair. Allograft provide mechanical reinforcement, and that leads to lower retear rates and better functional results. Synthetic grafts have demonstrated to have superior biomechanical properties, but are unable to provide the same biologic scaffold that allograft tissue provides, and xenografts in general are inferior to allografts due to the inflammatory response that they elicit, but here it's not true at all, because it's dependent on which kind of xenograft you use, because if the xenograft is pure, is not this is the true story. So, in conclusion, we have to state that the not cross-linked porcine collagen scaffolds show superior result for cell adhesion and proliferation, as well as on histological evaluation. And which kind of technique is more effective? We have tried to do everything. We put on the top, beneath, in the middle, cover the suture, beneath the suture. I don't know. At the time, I don't know which is the best technique that we have to do and that we have to perform. But we have to try a lot of techniques in order to improve it. So the ABM is very, very low. And for this reason, we have to have a high-level research evidence. And for this reason, we have to try to understand our experience, which can help, and what can help to understand, if it's possible to understand something more about the patch and the using the patch. We started in 2007 with a pericardial equinus in an augmentation repair by Snyder techniques, with a patch that cover all the cuff, and but we have a bone edema of the humeral head, and maybe due to the alpha-gal antigenous that was not removed, and we had an immunoreaction as not self, so we refused it. The second experience was xenografts, always with Porchin-Delman patch in a bridging technique with good results, clinical results, but the MRI at 1 year follow-up is too bad. 73% of not healing in 2010, and we refuse it again. So we start with our third patch experience with always the xenograft, Porchin-Delman patch, that is published on shoulder and elbow. It's a prospective randomized control trial for patch augmentation, It's a study level 2 with 92 patients enrolled in the study. And the purposes of this study was to evaluate at the MRI the integrity of the cuff repair comparing the two groups, one with augmentation and the other one without the augmentation. And the primary hypothesis was that a better outcome defined as a tendon to bone healing could be achieved in the biological augmented group. The secondary hypothesis is important because we have a care above all about the thickness of the tendon and the footprint extension, and also the sign of the intensity of the sign of the tendon that is quite normal. In the materials we have, in order to achieve this kind of homogeneous groups of patients, because we have to compare peer with peer, not peer with apple. So we have strict inclusion criteria and exclusion criteria for the study, and we have a comparable patient data also for the lesion site in the study group and the control group, where 60%, about 60% was superior cuff tear, and also for the shape, with the crescent shape that is about 25%, and this is particular because at the MRI we check it. We check this our work with four different categories. One is healed but thin, one is partially healed, and one not healed at all. And the surgical technique that we have used, it was a single row repair, a medial single row repair, as Alex Castagna described, in a Snyder technique, with two peak medial anchor, with a tenotomy and a subarachnoid decompression in all patients, in all the group. So there is no doubt about that. And for the study group, we used For the study group, we use our goalpost technique with two simple structures that we tied in medially in the muscular tendon junction, in order to create and to fix laterally the patch over the footprint, and we create this is with crossing the suture, we create a toe suture with the patch. But it's important because the medial suture creates a lower tension over the cuff repair beneath the patch. So, and here is the results of our technique with the patch in the MRI imaging. We can see the patch over the footprint with the medial side and the repair of the cuff. So our results, we have to are very nice, and even when we consider healed and thin, but also when we consider only the healed tendon. And we have a statistical difference between the two groups, so we have to take care of that. And we approve it. But we have also other consideration that we have to understand the thickness of the tendon. That is also statistically, we have a statistical difference. Also the coverage of the footprint, that is very important. But for the strength and for the clinical assessment, there are no difference. And this was the data that we expected, of course. Another consideration is that in some cases, tendons appear torn after 6 and 12 months, but at the MRI, but at 24 months, the MRI revealed the continuity of the tendons. This can be an effect of the residual edema within the tendon that increase the signal intensity, and the resorption of this edema during the following months maybe revealed the continuity of the tendon or a new scar from tissue formation. We don't know. We have also two second looks because two patients of the augmented group suffered the rupture after traumatic events and mobilization of one lateral anchor, and at 6 and 8 months post-op. And the macroscopic examination revealed the complete integration of the patch without the possibility to distinguish between the previously repaired tendon and the previously healthy portion. And also the histological examination show a scaffold integration, tendon-like architecture and cellularity, minimal infiltration and degradation, but above all, no foreign body response and tendon healing at 6 months post-op. Now we have at our first experience in order to try to join our experience of patches and repair and our experience of repairable cuff. So when we have a partial chance to reduce the tendon to the native footprint, we prefer to use a true superior cuff beneath the cuff that we have to repair over the patch. So, in conclusion, our take-home message, I think that the patch should be pure, with alpha-gal antigens removed, not cross-linked, large enough to cover all the native footprint, and the technique should decrease the tension on the tendon repair and reduce the hardware use. And when we have a repairable cuff, the use of biological augmentation is safe and effective, and technically demanding, but reproducible, and it still remains very expensive. Thank you very much for your kind attention.